So a combination of all of those had led to the change. Now, if we were to walk into our clinics and try and investigate what this condition was in terms of issues, not unlike our case study. So we're going to work on those and give you a bit of an idea of what I meant in terms of freeing up TFL, the iliacus, also the myofascial work through the rectus femoris in terms of the prone knee bend restriction. And yeah, so the idea is to try and give you as a realistic flavour as I possibly can, even though that we don't actually have the client here or the athlete here. Now, when I'm looking at treating, especially the rectus femoris from a myofascial tension point of view, I always use the prone knee bend as the assessment tool. Everyone's familiar with prone knee bend, I take it, the test. If not, I can go through it with you if you like, just so that it'll re-familiar. Michael, can you spin over onto your front for us? Or lie prone. So prone knee bend, quite simple. It's not a difficult test. We're taking the heel towards the buttock, and the idea is that we're trying to find out, one, where the restriction in terms of range of movement from our point of view is, and the restriction range of movement from their point of view as well, and where they feel it. So can you just let me know when you start to feel a stretch?
Yeah, right at the end there's a little stretch.
Yep. Now where are you feeling that?
Yep, so a tiny bit medial. Just
yep.
Right, yeah.
So in that area there. So if I wind that up and I press there, is that the area?
Yeah, yep.
Yep.
So pretty mild. But
yep. And then if I wind it up more, is the influence more?
Yep.
Yep. Is in the same area?
Yeah, straight. Yep, that's the only spot I'm feeling it.
Okay, terrific. Let's look at this side. Once again, just tell me when you start to feel a bit of a stretch.
Yeah, same again. Just
same again then. So we're obviously getting a little bit closer through here. You're feeling that in a similar area?
Yeah, so just medial, just above the knee again.
Okay, all right. Terrific. All right, now spin over onto your back again for me, please. Okay, so the right obviously is the side that's tighter from one side to the other, and it's at that, thank you, it's at that end range. Now, when I wind up the range of movement, it's really important that you isolate and try and palpate where they're actually feeling it, okay? So that gives you an indication of whereabouts that's first restricted. I'll work through this first part here of the rectus femoris, and then we'll turn him back over and we'll recess it again and see what sort of change we get. And more than likely what you'll find is that the restriction, the range of movement will definitely improve, but the restriction will tend to go up the thigh, which is essentially what we want. Now, treatment-wise, I'm using a what we call a myowax or a myolube or whatever the case may be. It's sort of coconut oil and a bit of beeswax, so it's not, it's definitely not an oil, and it's definitely not a cream. So it's sort of in between those two, and the reason for that is so that we can engage the fascia a lot more effectively without actually slipping over it. So first principle in engaging the fascia is dragging up all the skin laxity, if you like, okay, and locking down onto the tissue, and then just applying a load through there. And I'm working on that medial, not vastus medialis, but just the medial portion of rectus femoris. And I can introduce just a little bit of movement. How's that feel, Michael?
Yeah, good. Just that burning drag, that mild burning drag.
Yep. Now, had I had brought in an electric table today, I would probably lift the table a lot more because it's a little bit lower, only because I need it low to do some of the techniques today. I would then probably engage with more liberally with the elbow. So take the tissue, engage, and then once again just slow, purposeful tension on the fascia, so we're working more towards the fascia than the muscle. And then just introducing just a little bit of range of movement, not more than 5 degrees of range of movement in terms of flexion. How are we going here, Michael? Is that?
Yeah, it's much deeper feeling. Yeah, before it's good.
Okay. All right, that's enough. All right, Michael, spin over onto your front for us. So I do a lot of to and froing in terms of positions with the clients. Okay, once again, just start to tell us when you start to feel a bit of a stretch. Nothing there?
If anything, maybe a little bit, yeah, right up the top.
Okay.
Yeah, nothing.
So let's put a little bit of hip extension into it just to add to the tension on the rec fem. More so there.
Yeah, about the same. It's very, very mild.
Yep.
Hardly notice it now, but
Yep.
yeah, high up on the rec fem.
So more up in that area.
Yeah, even a couple inches above that. Yeah.
Okay, so more up in this area here.
Yep.
Okay, good. Okay. All right, spin over onto your back again for us. Okay, so we've improved the range and it's obviously gone, sorry, and it's gone up towards the hip itself. Now, when we're engaging further up the hip, then we have to do is make sure that we don't start to venture off into the fascia of the adductors, okay, which is easy to do when the leg's sitting like that because everything rolls out towards that way. So we have to try and make sure that we move the leg back in medial and then engage from here. Make sure that we follow that line right up towards the hip, being the rec fem. So you'll notice that this technique is a slow technique. You're engaging the fascia, you're not engaging the muscle. How's that pressure? All right.
Good.
Yep. Not too
Not
too much
aggressive.
dominance on it.
No. That's right.
Make sure that the shoulders are relaxed.
I probably felt it even just medial to that
Yep.
when I was
Yeah.
on the stretch, but yeah, at that height.
So more in that
Yeah,
area there.
Yep.
Okay.
That's where I was feeling the stretch. But yeah, it was much lighter than before.
Okay. All right. That's good. All right. Spin over onto your front again. Now, we've had significant change in his range of movement already because we're able to take the heel towards the bum and not have any tension on it. So the idea is that we have to take it up into hip extension to put more of a stretch on that, that rectus femoris. Oh, that's great. That's good. How does that feel?
Yeah, there's no specific spot at all.
Yep, great. All right. So that's the effect we're looking for with that, to clear out that rec fem. Now, because he was tight on his Ober's test, everyone's familiar with their Ober's test, I'm assuming. Spin onto that side for me now, mate. I'll go through the Ober's test. Now, the Ober's test is important for runners for a couple of reasons. First and foremost, obviously the fascia, the gluteal fascia, that blends into the lower limb, particularly the ITB. It is the restricting force, if you like, for the ITB itself. So if you've got a tight ITB, more than likely it's the fascia up here in the gluteals that's actually tight, and that's causing the tension and load through the rest of that ITB, all those lateral structures themselves. Now, what we'll do, Michael, can I just get you to just get right onto your side there like that? That's good. Make sure this bottom leg's up and out of the way. And for those of you that have been at any of my other classes, this will be a refresher for you. Hip, knee and ankle all at the same height, okay, and letting the load drop down, okay, the knee. And that will give us an indication of what the ITB is like. Now, Michael's probably a little bit tight on this side. You'd like to see a good 10-degree drop, and he's probably at 5, if that. So we need to free that up. So that's tight compared to the other side. So let's free up this overs. So if you can just turn yourself in that way. So I'm going to start down here. There's his greater trochanter there. So I'm going to start at the top of the trochanter and then work my way up towards the iliac crest in a few different sweeps. Try and incorporate as much of that gluteal fascia as I can. Can you see that all right? So start at the greater trochanter. And just introduce a little bit of movement. How's that there, Michael?
Yeah, that's good. Yep, no pain.
Yep.
Just a bit of a stretchy.
So the idea is that once again, I'm not engaging the muscle, so therefore you shouldn't get any reactive tension or pain, meaning that you're not isolating and treating any trigger points that may be there, because let's face it, most people have got trigger points in their glutes. If they haven't, I'd be surprised. Okay, and I can slowly just bring the leg out into a bit of extension and drop the knee down as I work through that restriction as well. This obviously works a bit better when you've got an electric table, but yep, that's good. Now, when you're doing this particular type of technique, sometimes the client will feel a really strong pull on the inside of their knee, which is an indication that the adductors are pulling through there. So once again, we're looking at that balance between our hip abductors and our hip adductors. Okay. Okay, so you can see the difference there. So we're getting a good 10-degree drop, which is good. That's what we want. But it's just out of interest, Michael. Let's see what your other side is like without giving you too much of a... Okay. Yep, you just need to relax there. Just relax, relax, relax. Yep, so he's much better on that side. I did assess this beforehand and he was fairly good on this side, so that's good. Okay, terrific. All right, now back onto that side for me, please, Michael. Now we're going to clear out the wonderful Quadratus lumborum muscle. No, you're all right. You won't lose that. Now we're going to clear out the right one, just given the fact of the amount of time that we've got, but I'll show you the approach that I have. Now this is a technique that we're doing soft tissue wise, but also trigger point. What do we know? Most lower back pain, muscular lower back pain, can be attributed to our Quadratus lumborum friend. I find it so much more effective to treat Quadratus lumborum sideline. Gravity works for us there. Now we're going to work the superficial fibres first. So that means we've got them side lying, we've got the hip the leg extended. We pull down on the hip as well, so that it opens up that space and it brings up those superficial fibres first and foremost. When we go to treat the deep fibres, then the idea is that I'll bring the knee up, okay? It'll compress down, things will soften, and we can get into the deeper fibres of Quadratus lumborum. But always clear out the superficial fibres of your QL before you try and delve right down into those deeper ones. And if they're really reactive, don't even go to the deeper fibres, okay? It might just be a desensitising process to begin with. Okay, so we're going to go in. We've got our last rib, our iliac crest, and our vertebra in between. So we know all our attachments. We know where we need to be, about midway through. So if you find your paraspinals, or your rectus spines, whatever you'd like to call them, we come off those, and then we engage down into the tissue below, and we sink in. I love the word sink, so we don't force, sink our way in, and then engage onto that tissue there. How's that there, Michael?
Yeah, good. No,
all right?
No
yep.
real pain.
No. You could have worked on this for us. You could have. You and hands up. So I start at the lower attachment here, so right up against that iliac crest. So we engage in there. Can we see that? Into that lower attachment there. And look, unfortunately, Michael does actually feel reasonably good here. What do we feel for when we're working through this sort of tissue, or we're working through tissue? Feedback. How much pressure and how much feedback do I get from it? So do I put a little bit of pressure in there and get an enormous amount of feedback, meaning that it's very sensitive or it's very tight? Or can I put a lot of pressure and get very little feedback? And that's what I'm getting with Michael.
Yeah, when you went a bit firmer than I did, yeah, right where you are now.
Yeah. So now I'm in the upper part, just below that last rib.
Yeah, that is definitely much more painful.
Yep. Okay, so you feel fairly good superficially. Let's see what you like on the deeper approach. Okay. So now there is that trigger point that likes to live underneath your iliac crest. So if you come in, there's the top of your iliac crest. To get to it, you need to sink down and underneath that iliac crest, okay? And it's down there that it lies in those deep, deep fibres. So therefore, I need to come in from this way. So once again, I sink in and then sink up against that iliac crest. Okay, so I'm going down and then into the deeper reaches of that. How's that there?
Yeah, it's probably about a 5 out of 10.
Yep. Okay. So we're getting, and I'm getting a little bit of feedback, and this will refer over to the upper part of that glute muscle. Now, if you find you're having difficulty getting in there with your fingers, then there is the opportunity to use the forearm. But if you're doing that, I'm sorry if you've got really big forearms, I haven't got real big forearms, but we can sink into it. Might just have to open you up just a fraction more, that's it. So we sink in, and then to get to there, we turn left. And then just sink into that tissue there. How's that there, Michael?
Yeah, it's the same spot as before.
Yep.
About the same 5 out of 10.
5 out of 10, good. So I like to treat between that 6 and 7. I'm not a firm believer in the engaging 8 or 9, just because you'll get too much feedback and you're defeating the purpose of what you're trying to do. Okay. So we can keep engaging and treating that area. Get him back up and check his lateral flexion. One side down to the other. How does that feel now? Is the tensional offloaded? Is there a change? Is there an increase in range of movement? All right, now just onto your back for us again, please, Michael. Now with any knee pain, biomechanically, most of the soft tissue dysfunction around a knee will be the fact that you've, the patellofemoral joint or patellar tracking problems. The VMO becomes weakened or overloaded for whatever reasons, and therefore your lateral structures of your thigh then take over and become tight. So therefore you migrate the patella to one side. You don't have to have that happen, but vastus medialis, a lot of the time in most of the runners and riders that I treat, you will find will have trigger points in and around that vastus medialis, and it's really important in terms of treating any knee pain that you clear out that myofascial trigger point activity around there, especially that vastus lateralis. And let's face it, it is a big muscle. That whole lateral part of that thigh there is vastus medialis. You've got ITB that lies over the top of it, but it is a big muscle. You have 4 trigger points in the lower part. So we have 1, 2, 3, 4. Then we have another 3 here, another one there, and another one underneath. So there's lots of trigger point activity in the vastus medialis. Lateralis. Thank you.
Yeah, it's pretty tender.
Yeah. Yeah, 0 to 10, we're...
Yeah, 6, 7.
Yep,
just without
yep.
pressure.
So that's tolerably uncomfortable.
Yep.
Yep.
Yeah.
And you can always tell because he's not working against me. If they're working against you, then you're pushing the boundaries. Okay, so we'll clear out those lower portions of vastus medialis, and it's at this point that I do 3 or 4 minutes of this particular type of work, and then I would do what? I would get Michael back up and he would do a one-legged squat for me to tell me how it feels. So we get him back up and he'd do a one-legged squat. Do you want to do a one-legged squat for us?
Yeah.
I know we didn't test it beforehand, but before Michael came in, there was a bit of deviation to one side. Yeah, we'll just move this out of the way. Yep. So you can go down for us. So the idea is that I'd get him to go down, do the one-legged squat. Once again, can he go any further? Hold it, come back up. With the particular athlete that I had, to reproduce his pain, he would go down in the one-legged squat, hold, and then he would have to hop, okay, to really load it up. And it was on that hop, and then when he'd catch it on the way back down, that's when it'd bring on that awareness. So yeah, let's get you to do that.
With the hop?
With the hop. Let's just see it in practice. Yep, good. Okay, anyway, that just gives you the indication of the retest component of it.
Stable.
Did it? Of course. Okay, so we've done rectus femoris, quadratus lumborum, and our vastus lateralis. Now, one of the most important ones will be our internal rotation. And I can touch on this with the next case study we're doing because it does also incorporate significant restriction. But the idea is that we take internal rotation of the hip. So we're roughly at about 35 maybe on this side. Sorry. And he's got a little bit more on that side, hasn't he? So no end of range tightness there, and yet he starts to wind up about here already, and then it just blocks out. So who are the culprits? Well, it could be hip flexors, it could be our adductor longus, it could also even be adductor magnus, TFL and glute med. First person I go for is wherever they feel it. So if I wind Michael up, where do you feel that?
Yeah, top of the thigh and just...
Yep, so you're getting that feeling down there. Yeah. So they may talk about having restriction, not pain, restriction in the front of their hip. They may even feel it deep into the groin. They may feel it in the back of their hamstring or in that inside of their hamstring. For Michael, we're going for TFL, with TFL and iliacus as well, both of those together. So what I'll do first is I'll do a little bit of trigger point work just through your iliacus, and then we'll finish up with some myofascial work on that TFL. Is that all right? Yep. So iliacus, just, everyone's familiar with iliacus. Okay, so we find the anterior superior iliac spine, which is about this point here. Can't miss that, big bony protuberance. And we sink down, and I always like to do it with a towel over, just to lessen it, to dampen the palpation. Sink in until I meet with a little bit of resistance, which is about now, and then hook back in towards the iliac fossa itself. So I'm hooking down and pulling in, okay? So that I'm now engaged on iliacus. I can't be on anything else. I don't think I should be, but I'm pretty sure that's where I should be. And then it's just a matter of working upwards and downwards, engaging that tissue. Just breathe, mate.
Yep.
Where are we at? Do you want me to lessen that a little bit?
Just the first one was a bit sore. But
Yep.
Yeah, that's.
So that's,
right,
yep, okay. So I don't need to be in here for a minute. It's just engage, influence. Okay, let's see what. So a little bit better on that end range, but still significant restriction. So let's see, Mr. TFL. And it's the posterior fibres of that TFL. So I'll bring the knee in, a little bit of lube through that TFL, like so, and we will engage.
Yeah, that spot you just went over,
Yep.
that's where I felt it. If anyway, that's the spot that felt restricted.
Okay.
Yeah, right there.
Okay, 3 sweeps. Yep, there it is there. You should notice a change straight away after you've done it. It should free it right up. So that end range is gone, and now we're out probably an extra 5 degrees. I'm not going to get him exactly the same as what he was on the other side, because this is his dominant side, so we'd have to do a lot of work on this side, and there'd be a glute influence as well on that side, but that certainly freed it up compared to the other side. Let's just do one more, see if we can't. Now, it doesn't mean that if you just keep working on this all day, that you'll just keep freeing it up. You'll get a significant change, and then it'll plateau out, and that will be it. Okay. Yep. Yep, that's good. Okay. All right. That's about as much as we can get through in terms of the technical demonstration for this case study.
Well, thanks very much everyone for coming this afternoon to listen to Stuart. I hope you've enjoyed it. It's been very engaging, and we hope to see you again next time. Thank you very much.
Thank you.